Okay, so let's start with a pathway that can cause widespread trouble. The metabolic complications of diabetes mellitus. I'm thinking specifically about cataracts, retinopathy, and peripheral neuropathy.
Hmm.
What's so striking here, I think, is that a single core problem seems to drive all three, something called sorbitol accumulation.
That's exactly right.
Hmm.
Think of it this way. When your blood sugar is persistently high, like in chronic hyperglycemia, the body tries to process that extra glucose through this alternative pathway.
Okay.
And this pathway produces sorbitol. Now, in certain cells, like those in the lens of your eye, the retina,
Mm,
and importantly, the Schwann cells that insulate your nerves, there's a relative deficiency of an enzyme.
an enzyme.
Yeah, called sorbitol dehydrogenase. Its job is to break down that sorbitol.
So if that enzyme isn't working efficiently, sorbitol just builds up inside these cells. Is that it?
Precisely, it accumulates. And this buildup creates an osmotic problem,
Mhm.
basically. It draws water into the cells,
Ah,
causing them to swell and ultimately leading to damage. It's like the cell is trying to cope with this sugar it can't properly get rid of,
yeah,
and it just gets overwhelmed.
that makes sense.
What's fascinating is how this single underlying mechanism translates into such, well, very clinical pictures.
And it really does, doesn't it? In the eyes, we see diabetic retinopathy. Now, this condition has two main forms, right?
Hmm.
There's the non-proliferative stage, which involves early vessel damage like small leaks, dot plot hemorrhages,
Very
microaneurysms.
initial signs.
And then the more severe proliferative form, that's where new fragile blood vessels actually grow on the retina,
Neovascularization, yeah. Very dangerous.
which can bleed and scar. And it's crucial to understand diabetic retinopathy isn't just an eye problem. It's strongly linked to cardiovascular disease.
The very important link.
Definitely. And beyond the eyes, that same sorbitol accumulation can lead to diabetic neuropathy, causing nerve damage throughout the body.
A really common complication.
And cataracts, another very common cause of impaired vision in diabetics.
Given these potential long-term consequences, early detection of diabetes is absolutely critical.
So how is that typically done?
Well, the initial screening often involves a 1-hour, 50-gram glucose challenge test. This is especially common in pregnant individuals, usually between 24 and 28 weeks.
And what's considered abnormal there?
Values of 140 milli-GDL or greater. The cornerstone of management, of course, is tackling that chronic hyperglycemia.
Through lifestyle changes first, I assume?
Exactly. Diet and exercise are key, alongside pharmacotherapy, which could be insulin or various oral antidiabetic agents.
Okay.
And here's a fascinating little aside related to neuropathy, but not diabetes directly. Did you know that pyridoxine, which is vitamin B6,
Mm-hmm.
can actually prevent the peripheral neuropathy caused by the antituberculosis drug isoniazid, or INH?
Oh, interesting. I didn't know that connection.
And conversely, corticosteroids, which are powerful anti-inflammatories, can sometimes cause cataracts. It just underscores how interconnected these metabolic pathways are with our overall health and how different factors can influence them. But the diabetes complications really stem from that chronic high sugar, the sorbitol buildup, and the osmotic damage.
Okay, now let's pivot a bit. Let's talk about the incredible complexity of our immune system and, well, what happens when it has missing links in its defense?
Right.
Imagine your body's most elite defense force suddenly facing, like, internal sabotage. We're going to uncover some of those missing links, starting with a really crucial part, the complement system.
The complement system is fascinating. It's like a cascade, a series of proteins that have to work together perfectly to identify and eliminate pathogens.
It's like dominoes falling.
Kind of, yeah.
Yeah.
And when certain parts of this cascade are missing, very specific vulnerabilities pop up.
A prime example you mentioned is recurrent Neisseria bacteremia. This condition often points to a deficiency in the terminal complement components, specifically C5 through C9. What's the impact of missing those specific ones?
So without those C5 to C9 components, the body can't form something called the membrane attack complex, or MAC.
MAC. Okay.
Think of the MAC as a molecular drill. It punches holes in the outer membrane of certain bacteria, particularly Neisseria species.
Ah, so it's a direct weapon against them.
Exactly. Without it, these bacteria are incredibly difficult to clear. So individuals with this deficiency are highly susceptible to recurrent Neisseria infections.
And that includes meningitis.
Yes, Neisseria meningitis is a common culprit, often leading to meningitis. Diagnosis confirms the specific complement deficiency, and treatment involves targeted antibiotics like ceftriaxone or penicillin G.
It really highlights how vital each piece of that immune puzzle is.
Absolutely.
And it's not just about direct bacterial destruction, is it? The complement system also plays a role in regulating inflammation. Take hereditary angioedema.
Right, HAE.
Another fascinating complement-related issue. This is due to a deficiency in the C1 esterase inhibitor. So what goes wrong there?
This deficiency basically unleashes an enzyme called kallikrein, which then triggers an out-of-control surge in bradykinin. Bradykinin is a powerful mediator that causes blood vessels to become leaky.
Leaky vessels, meaning?
Fluid leaks out into the tissues, leading to the characteristic, often quite severe, swelling we see in angioedema.
That makes sense. And isn't angioedema also a side effect of ACE inhibitors?
It is, yes,
Yeah.
because ACE inhibitors also interfere with bradykinin breakdown, so it's a similar mechanism in play. For HAE, confirming the C1 esterase inhibitor deficiency is key for diagnosis. The central defect is really that inhibitor deficiency, and bradykinin is the main driver of the swelling.
Okay, let's shift gears slightly within the immune system. Let's explore deficiencies in our cellular and humoral immunity, the B cells and T cells. First, X-linked agammaglobulinemia, also known as Bruton's.
Right, XLA.
This is a condition caused by a defect in the BTK gene, which codes for a crucial enzyme, a tyrosine kinase. What's the consequence of that specific defect?
This BTK defect means B cells, which are absolutely vital for producing antibodies, can't properly mature, they get stuck in development.
So what does that look like in the patient?
In these patients, you'll find virtually no mature B cells circulating in their peripheral blood. And consequently, they have very, very low levels of all classes of immunoglobulins or antibodies.
Okay, no B cells, no antibodies.
Pretty much. What's particularly interesting is the timing. Symptoms typically emerge after 6 months of age.
Why then specifically?
That's exactly when the protective maternal antibodies, the IgG that crosses the placenta, start to decline in the baby's system.
Ah, so once mom's antibodies are gone, the baby's own system can't pick up the slack.
Precisely. The body is left quite defenseless against certain types of infections. Patients then experience recurrent bacterial infections, particularly encapsulated organisms like Haemophilus influenza, Streptococcus pneumonia, and also enteroviral infections. These often affect the sinuses, lungs, and the GI tract.
Any other clues?
A diagnostic clue can be absent or really scanty lymph nodes and tonsils, reflecting that lack of B-cell areas. Diagnosis confirms the absent B cells and those profoundly low immunoglobulin levels.
And how is it managed?
It requires lifelong management. Regular intravenous immunoglobulin, or IVIG, infusions to replace those missing antibodies.
Okay. Next up, DiGeorge syndrome. This sounds like a very different kind of immune deficiency originating from a genetic error.
Yes, it's typically caused by a specific genetic deletion on chromosome 22, the 22q11 microdeletion.
And how does that deletion impact immunity?
This microdeletion leads to a failure in the proper development of the third and fourth branchial or pharyngeal pouches during fetal development.
Okay, and what do those pouches normally become?
Crucially, they're supposed to form the thymus gland and the parathyroid glands.
Ah, so the consequences are.
Direct consequences are T-cell immunodeficiency, because the thymus is where T cells mature. If it's missing or underdeveloped, aplasia or hypoplasia, you don't get enough functional T cells.
And the parathyroid.
Hypoparathyroidism, which leads to hypocalcemia or low calcium levels. So you often see immune problems and calcium problems.
Interesting combination.
Definitely. Beyond immunity and calcium, these patients often have characteristic facial features and common contratruncal cardiac defects issues with the major arteries leaving the heart. Diagnosis is confirmed by finding that 22q11 microdeletion.
Is there a treatment for the immune part?
For severe T-cell deficiencies, sometimes a thymus transplant can be an option.
Okay, let's talk about hyper-IgM syndrome next. The name suggests high IgM, but what's the actual problem?
Right, the name is a bit counterintuitive. The core defect here is usually in the CD40 ligand, or CD40L, which is found on activated T helper cells. This ligand needs to interact with CD40 on B cells to tell them to class switch.
Class switch, meaning switch antibody types.
Exactly. B cells initially produce IgM, but they need that T cell help via CD40 interaction to switch to producing IgG, IgA, or IgE. Without functional CD40L, they can't make that switch.
So they get stuck making IgM.
Correct. You end up with normal or even high levels of IgM, but very low levels of IgG, IgA, and IgE. This leaves patients susceptible to severe bacterial infections, especially pyogenic ones, early in life.
And because T cell help is involved, are there other issues?
Yes. They're also prone to opportunistic infections like pneumocystis, cryptosporidium, CMV, because that T-cell interaction is crucial for other immune functions too. Diagnostically, you see the characteristic immunoglobulin pattern and a failure to form germinal centers in lymph nodes. Treatment often involves IVI, similar to XLA.
Now, leukocyte adhesion deficiency, type 1, LAD1. This sounds like a problem with immune cells getting to where they need to go.
That's exactly it. The defect is in an integrin protein called LFA1, specifically the CD18 subunit, on the surface of phagocytes like neutrophils.
And what does LFA1 normally do?
It acts like molecular Velcro, allowing neutrophils to stick to the blood vessel walls and then migrate out into infected tissues. It's crucial for chemotaxis, following the chemical trail to the infection site.
So if LFA1 is defective,
The neutrophils can't get out of the bloodstream effectively. They can't migrate to the site of infection. So patients get recurrent bacterial infections, particularly of the skin and mucosal surfaces, but characteristically, these infections lack pus formation because the neutrophils aren't there.
lack of pus. That's distinctive.
Very. And another hallmark sign is delayed separation of the umbilical cord, often after 30 days, because neutrophil migration is needed for that normal process too.
Hmm.
Diagnosis involves showing that neutrophils can't migrate properly.
Okay, another one with a distinctive name, Chidiac-Higashi syndrome. What's going on here?
This is caused by a mutation in the LYST gene. This gene is involved in regulating lysosomal trafficking, basically how things move around inside the cell, particularly involving lysosomes.
And the functional consequence?
The defect leads to microtubule dysfunction, which messes up the fusion of phagosomes, vesicles containing engulfed material, with lysosomes, vesicles containing digestive enzymes. So phagocytes can engulf bacteria, but they can't efficiently kill them.
What does this look like clinically?
It presents with a unique combination of features: partial oculocutaneous albinism, so light skin, hair, and eyes; recurrent pyogenic infections because of that phagocyte defect; and progressive peripheral neuropathy.
Albinism and immune problems. Interesting mix.
Yes, and they also have neutropenia, mild coagulation defects, and characteristically you see these giant granules inside their granulocytes and platelets when you look under a microscope.
Giant granules.
Yes, that finding is diagnostic. Treatment is often a bone marrow transplant.
And finally, for this section on immune deficiencies, let's talk about chronic granulomatous disease, or CGD. This involves a fundamental problem with how certain immune cells, neutrophils especially, kill engulfed pathogens, right?
Exactly. The core defect here is in an enzyme complex called NADPH oxidase.
NADPH oxidase. What does it do?
This complex is supposed to generate reactive oxygen species, ROS. Think of them as tiny, highly destructive oxygen compounds, like superoxide. Neutrophils use these ROS in something called a respiratory burst to kill bacteria and fungi they've engulfed.
So in CGD, that burst is defective.
Precisely. If NADPH oxidase is defective, this burst is impaired or absent. Patients with CGD are therefore highly susceptible to infections with a specific group of organisms, catalase-positive organisms.
Okay, why specifically catalase-positive organisms? That seems very specific.
It's a great question. Catalase is an enzyme that breaks down hydrogen peroxide, HOB-URO.
Right.
Normally, neutrophils can use the HO generated during the respiratory burst, or scavenged HO, and convert it via another enzyme called myeloperoxidase, MPO, into hypochlorous acid, essentially bleach, which is very effective at killing microbes.
Okay, so they make their own bleach.
Basically, yes. But in CGD, the neutrophils can't produce their own HOF effectively because the NADPH oxidase isn't working. Now, some bacteria produce HOs themselves, and a CGD neutrophil could potentially use that bacterial HO with its MPO. But catalase-positive organisms like Staphylococcus aureus, Serratia, Burkholderia, Nocardia, Aspergillus produce catalase, which breaks down HO. So they destroy the very weapon the CGD neutrophil might have been able to borrow.
Got it. So the catalase negates any HOs that might be around, and the neutrophil can't make its own.
Exactly. It completely cripples the neutrophil's ability to kill that particular bug. This leads to recurrent, severe infections, pneumonia, abscesses, osteomyelitis, and often granuloma formation in various organs. As the immune system tries to wall off infections it can't clear.
How is it diagnosed?
Diagnosis is done with specialized tests that measure the respiratory burst, like the dihydroamine DHR flow cytometry test or the older nitroblue tetrazolium NBT dye reduction test. The DHR test is more common now.
It's a vivid illustration of how one enzymatic defect creates such a specific, devastating vulnerability.
It really is. And it emphasizes why knowing the specific organisms involved is so important in managing these patients.
All right, let's shift focus now. We've talked about immune deficiencies, but what happens when our normally protective immune system goes into overdrive? We're talking about hypersensitivity reactions.
Yes, essentially exaggerated or inappropriate immune responses that cause tissue damage.
There are four main types, right? Each with its own distinct mechanism.
Absolutely. Think of them as different ways the immune system can kind of misfire and end up harming the body.
Let's start with type hypersensitivity. This is the immediate kind of reaction we often associate with allergies. What's happening at the cellular level there?
This involves IgE antibodies. When an antigen, like say pollen or a peanut protein, cross-links specific IgE antibodies that are already bound to the surface of mast cells.
Mast cells in the tissues.
Exactly, found in tissues. This cross-linking triggers their rapid degranulation. Basically, they dump out preformed mediators like histamine and tryptase.
And histamine causes?
It causes immediate effects like itching, pruritus, hives, urticaria, wheezing, increased mucus production. There's also a late phase, hours later, driven by other mediators released by mast cells, attracting eosinophils and causing more prolonged inflammation.
And the severe form is anaphylaxis.
Yes, anaphylaxis is the most severe, life-threatening form. It's a systemic reaction involving difficulty breathing, dyspnea, bronchospasm, potentially respiratory arrest, a dangerous drop in blood pressure, hypotension, and shock. It's a true medical emergency.
Okay, then there's type 2 hypersensitivity. You mentioned this involves antibodies directly attacking cells. How does that work?
Here, antibodies, usually IgG or IgM, bind directly to antigens that are on the surface of your own cells, or sometimes on extracellular matrix components.
And what happens after they bind?
This binding can trigger several damaging mechanisms. It might mark the cell for destruction by phagocytes or the complement system. It can cause inflammation via complement activation, or it can directly interfere with the cell's normal function without necessarily killing it.
Can you give some examples?
Sure. Autoimmune hemolytic anemia, AIHA, where antibodies destroy red blood cells. Goodpasture syndrome, attacking kidney and lung basement membranes. Myasthenia gravis, where antibodies block acetylcholine receptors at the neuromuscular junction. Graves' disease, where antibodies stimulate the TSH receptor, causing hyperthyroidism.
And you mentioned transfusion reactions earlier.
Yes, an acute hemolytic transfusion reaction is a classic example of type 2. If you're given ABO-incompatible blood, your pre-existing anti-A or anti-B antibodies, which are typically IgM, rapidly attack and destroy the donor red blood cells via complement activation.
Leading to serious problems quickly.
Very quickly. Within minutes to an hour, usually, you can see fever, chills, back pain, hemoglobinuria, hemoglobin in the urine, acute kidney injury due to acute tubular necrosis, and even disseminated intravascular coagulation, DIC. It's a major immediate crisis.
Okay, moving on to type 3 hypersensitivity. This one involves immune complexes. What does that mean exactly?
Right. So instead of antibodies binding directly to fixed cell surfaces, here, antigens and antibodies, usually IgG, form complexes that circulate in the bloodstream.
So they're floating around?
Initially, yes. These antigen-antibody complexes, or immune complexes, can then deposit in various tissues, especially places with high blood flow or filtration, like small blood vessels causing vasculitis, joints, or the kidney glomeruli.
And what happens once they deposit?
Once deposited, these complexes activate the complement system. This activation releases factors that attract neutrophils to the site.
And neutrophils cause damage.
Yes, the recruited neutrophils arrive and try to engulf the immune complexes, but in the process, they release lysosomal enzymes and reactive oxygen species, which damage the surrounding tissue. It's often called innocent bystander damage.
What are some conditions caused by this?
Classic examples include systemic lupus erythematosus, SLE, especially lupus nephritis, post-streptococcal glomerulonephritis, serum sickness, which is a reaction to foreign proteins like certain medications, rheumatoid arthritis, and various forms of vasculitis like polyarteritis nodosa or IgA vasculitis.
Serum sickness is kind of the prototype.
It's often considered the prototype type 3 reaction, yeah. Antibodies form against a foreign protein, complexes circulate, deposit, and cause symptoms like fever, rash, joint pain, maybe a week or so after exposure.
And finally, Type IV hypersensitivity. What makes this one unique? You said it doesn't involve antibodies at all.
That's the absolute key distinguishing feature. Type IV is entirely T-cell mediated. No antibodies are directly involved in causing the tissue damage.
So how do T cells cause the problem?
There are two main ways. First, CD8 cytotoxic T lymphocytes, CTLs, can directly recognize and kill target cells displaying a specific antigen. Second, CD4 helper T cells, specifically Th1 and Th17 types, recognize an antigen presented by antigen-presenting cells and then release cytokines.
And the cytokines cause inflammation.
Exactly. These cytokines recruit and activate macrophages and other inflammatory cells, leading to tissue damage. Because this recruitment and activation takes time, type 4 reactions are often called delayed type hypersensitivity, DTH. They typically take 24 to 72 hours to fully develop.
What are common examples of type 5?
The classic example is allergic contact dermatitis, think poison ivy, or nickel allergy rash. The tuberculin skin test, PPD test for PB exposure, is also a type 5 reaction. Graft versus host disease, GVHD, after transplantation is another important one.
Tell me more about graft versus host disease. How does that fit type 5?
So in GVHD, it's the donor's T cells present in the transplanted tissue, like bone marrow or sometimes solid organs, that recognize the recipient's tissues as foreign, usually due to differences in HLA molecules.
So the graft attacks the host.
Precisely. Those donor T cells become activated and attack various host organs, commonly the skin, causing a rash, the liver, and the GI tract, causing diarrhea. It's a T-cell mediated attack on host cells, fitting perfectly into the type IV category. It can sometimes cause hypereosinophilia too. Preventing GVHD often involves careful HLA matching and immunosuppressive drugs.
Okay, for our final segment, let's transition to some really fascinating and sometimes quite frightening conditions driven by specific bacterial toxins and their unique ways of causing disease.
Yes, these really illustrate how a single molecular weapon from a microbe can cause dramatic systemic effects, a kind of microscopic precision strike.
Let's start with hemolytic uremic syndrome, or HUS. We know it involves red blood cell destruction and kidney problems. What's the bacterial connection?
HUS is often caused by specific strains of Escherichia coli, particularly the O157.H7 serotype, that produce something called Shiga toxin.
Shiga toxin, what does it do?
This toxin directly damages the endothelial cells, the cells lining your small blood vessels, especially within the kidney's filtering units, the glomeruli. And what happens when those cells are damaged?
This damage triggers platelet activation and the formation of tiny blood clots, microthrombi, within these small vessels.
Okay.
As red blood cells try to squeeze past these microthrombi, they get physically sheared apart, leading to microangiopathic hemolytic anemia. You actually see fragmented red blood cells called schistocytes on a blood smear.
So that explains the hemolysis. What about the other features?
The platelets get used up forming these clots, leading to thrombocytopenia, low platelet count. And the damage and clots in the kidneys lead to acute kidney injury, AKI.
So the classic triad is?
Microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. Patients might also have fever or neurological abnormalities and some related syndromes like TTP, but that triad is key for HUS, especially post-diarrheal HUS linked to E. coli.
How is it managed? It's mainly supportive care. Plasma exchange is more central to TTP, but supportive management, including dialysis if needed, is crucial for HUS. Importantly, antibiotics are generally avoided for E. coli O157.H7 because they might increase toxin release. It's a really stark reminder of how a bacterial toxin targeting endothelial cells can trigger this dangerous cascade.
Absolutely. Okay, moving on to tetanus. A terrifying disease caused by Clostridium tetani. Its toxin causes a very specific kind of rigid paralysis.
Yes, the toxin is called tetanospasmin. Its mechanism is incredibly specific. It travels up motor neurons to the spinal cord.
And what does it do there?
It blocks the release of inhibitory neurotransmitters, specifically GABA and glycine, from special interneurons called Renshaw cells.
So it blocks the off signals to muscles?
Exactly. Renshaw cells normally help regulate motor neuron activity, providing inhibition. Without GABA and glycine release, motor neurons fire continuously and uncontrollably,
Leading to
severe muscle spasms and spastic paralysis. The classic signs are lockjaw, or trismus, inability to open the jaw, a sardonic smile, rhesus sardonicus, and a pistotonus, which is a severe, painful arching of the back and neck.
truly frightening, but preventable.
Absolutely crucial point. Tetanus is vaccine preventable through routine DTaP-ectotree vaccinations using the tetanus toxoid. If someone does get tetanus, treatment involves tetanus immune globulin, taken to neutralize circulating toxin, aggressive wound debridement, antibiotics like metronidazole, and muscle relaxants like benzodiazepines to manage the spasms.
Okay, now in stark contrast to the rigidity of tetanus, we have botulism, caused by Clostridium botulinum. This causes a flaccid paralysis. How does that happen?
Botulinum toxin, which is actually one of the most potent toxins known, works at the neuromuscular junction where nerves meet muscles.
And what does it do there?
It prevents the release of the excitatory neurotransmitter acetylcholine, ACA, from the presynaptic terminals of motor neurons.
So it blocks the go signal to muscles?
Precisely. If ACE isn't released, the muscle doesn't receive the signal to contract. This leads to weakness and flaccid paralysis. Characteristically, it's a descending paralysis, often starting with the eyes, diplopia, aphasis, then affecting facial muscles, swallowing, and eventually respiratory muscles.
And how do people typically get botulism?
Foodborne botulism comes from improperly canned foods containing the preformed toxin. Infant botulism, famously linked to honey ingestion in babies under 12 months, occurs when spores are ingested and germinate in the gut, producing toxin there. Wound botulism is rarer.
Leading to floppy baby syndrome.
Yes, that's the term for infant botulism: profound weakness, poor feeding, constipation, loss of head control. Diagnosis is primarily clinical, confirmed by detecting the toxin. Treatment involves respiratory support and specific antitoxin, equine antitoxin for adults, human-derived botulism immune globulin, or Big Four for infants.
Okay, another clostridial disease. Gas gangrene, caused by Clostridium perfringens. This sounds nasty.
It is. Gas gangrene, or myonecrosis, is a rapidly progressive, life-threatening infection of muscle tissue. The key virulence factor here is alpha-toxin.
Alpha-toxin, what does that do?
Alpha-toxin is a lecithinase, which is a type of phospholipase. It breaks down lipids in cell membranes, causing widespread tissue destruction, myonecrosis, and hemolysis, red blood cell destruction. C. perfringens also produces gas, hydrogen, and carbon dioxide, as it ferments tissue carbohydrates.
So that's where the gas in gas gangrene comes from.
Exactly. Clinically, it often develops after deep penetrating trauma or surgery, contaminating the wound with spores. It presents as rapidly spreading, extremely painful soft tissue necrosis, often with discoloration, edema, foul-smelling discharge, and crepitus, that crackling sensation under the skin due to the gas bubbles.
How is it treated? It sounds urgent.
It's a surgical emergency. Treatment requires immediate and aggressive surgical debridement to remove all dead tissue, high-dose antibiotics like penicillin and clindamycin, and sometimes hyperbaric oxygen therapy, which can help inhibit toxin production and kill the anaerobic bacteria.
Finally, let's touch on toxic shock syndrome and scarlet fever. You mentioned earlier these are both mediated by something called superantigens. Can you explain that again?
Right. Superantigens are a class of bacterial toxins that cause a massive, non-specific activation of T cells. Normally, a T cell only gets activated by a specific antigen presented in a very controlled way.
Okay.
Superantigens bypass this specificity. They directly link the T cell receptor to the MHC class II molecule on antigen-presenting cells, regardless of the peptide being presented. This triggers polyclonal activation of a large fraction of T cells.
Leading to a huge immune response.
Exactly. A massive uncontrolled release of inflammatory cytokines like TNF-alpha and IL-1, leading to systemic symptoms. For toxic shock syndrome, TSS, the classic superantigen is TSST1, produced by certain strains of Staphylococcus aureus.
And what does TSS look like?
It typically presents with sudden high fever, vomiting, diarrhea, muscle aches, confusion, and a characteristic sunburn-like rash that later desquamates, especially on the palms and soles. It's often associated with prolonged tampon use or nasal packing, but can occur with other staph infections. It can rapidly progress to hypotension, shock, and multi-organ failure. It's a reportable disease.
And scarlet fever, also a superantigen.
Yes, scarlet fever is caused by erythrogenic exotoxins like SPE, B, or C, which are superantigens produced by Streptococcus pyogenes, group A strep.
But it looks different from TSS.
It does. While it also involves fever and systemic effects due to the toxin, the rash is different. It's typically a diffuse red, sandpaper-like rash, often more prominent in skin folds, Pastia's lines, accompanied by a flushed face with pallor around the mouth and a strawberry tongue. It usually follows a strep throat infection.
So same mechanism, superantigen, but different toxins, different bacteria, different clinical picture.
Precisely. Both illustrate the profound systemic effects that can result from this uncontrolled, widespread T-cell activation driven by a single type of bacterial toxin. Management for TSS involves removing the source, like a tampon, fluids, pressors, and antibiotics targeting staph. For scarlet fever, it's primarily treating the underlying strep infection with penicillin.
Wow, what an incredible journey we've taken today, really diving deep into the intricate workings of the human body, especially when things go awry. It's truly amazing, isn't it, to reflect on the sheer range of ways our systems can be challenged
It really is.
and how incredibly precise our understanding of these underlying mechanisms has become.
Hmm.
From faulty enzymes like in CGD to missing immune components like in George, or even these microscopic toxins from bacteria.
Each story is really a testament to the body's intricate and often delicate balance.
Absolutely. And knowing the why behind the what, I mean, it doesn't just inform, it really empowers, doesn't it?
It absolutely does.
Hmm.
Understanding these precise mechanisms offers crucial insights into how we diagnose, how we treat, and sometimes even how we might prevent these conditions. It's about moving beyond just recognizing symptoms
Right.
to truly comprehending the molecular and cellular choreography of disease. That allows us to anticipate problems and intervene much more effectively.
Yeah, thinking ahead. And as we wrap up this deep dive, maybe something to consider is this. So many of these conditions highlight just how delicate that balance within our biological systems truly is,
Mhm.
where a single missing enzyme or a tiny bacterial toxin can trigger this huge cascade of dramatic, far-reaching effects. It makes you wonder what other hidden connections and delicate balances might still be waiting to be uncovered.
That's the exciting frontier, isn't it? Uncovering those connections could completely transform our understanding of health and disease.
And perhaps, eventually, help us prevent these challenges entirely. Food for thought.